Welcome back to the episode 3 of Clinical Topic Series. And today we are going to talk about abdominal aortic aneurysm. So let's start firing the questions. The first question is, can you describe briefly what exactly is abdominal aortic aneurysm and what is the pathophysiology behind it?
I'll just start with the definition of term aneurysm. So aneurysm is nothing but the dilatation of abnormal dilatation of a blood vessel. We're talking about aorta in this case. It can happen in any other vessel as well, splenic artery or femoral arteries.
Yeah.
By definition, in the case of aorta, it is more than 3 centimeters. If the diameter of abdominal aorta is more than 3 centimeters, that's called as an aortic abdominal aneurysm.
Yeah.
In most people, it ranges between 1.5 to 2 centimeters.
Yeah.
And in terms of pathophysiology, it's a disease related to your age, related to a few risk factors that we'll talk about shortly.
Yeah.
And with age, you tend to lose your elastin and collagen, essentially lose your connective tissue in the walls of the blood vessel. That leads to this abnormal ballooning or dilatation of a portion of the blood vessel, which we call as aortic aneurysm.
Okay, perfect. And can you speak a bit more about the risk factors for AAA?
The classic risk factors for AAA are high blood pressure, high cholesterol. The really key one is family history. Other risk factors, some of which sort of overlap with dissection, is history of connective tissue disease, history of arthritis, infections like syphilis.
Yep.
But to remember, key ones are that's family history, high cholesterol, high blood pressure, and not to forget lifestyle problem, which is smoking. And again, it kind of dramatically increases your risk of having vascular problems, and aneurysm is one of them. I'd also like to point out briefly here how a true aneurysm is different from pseudoaneurysm. As I said, true aneurysm, the dilatation is abnormal, and you still have 3 layers of your blood vessel wall all around the aneurysm, all around that abnormal dilatation. When I say 3 layers, is tunica, intima, media, adventitia. Adventitia is again the outermost, and intima is the innermost.
Yeah.
In case of a pseudoaneurysm, which we typically see in somebody who's got a recent cardiac procedure done, recent angiogram, recent procedure where they've had a catheter inserted into any of their arteries, that can damage the arterial wall and lead to formation of a pseudoaneurysm.
Yeah.
The other more commonly seen scenario in our cases in the emergency departments is when you see somebody with history of IVTU, injecting and coming with pain or traumatic groin swelling. Sometimes we call it infected pseudoaneurysm. And when I say pseudoaneurysm here, it means there is still an abnormal dilatation of the blood vessel wall, which was incited by trauma from the needle. And the difference is this doesn't have all the 3 normal layers around the aneurysm. This just has adventitia. So sometimes blood tracks between tunica media and adventitia, and the outer wall of the pseudoaneurysm is formed only by adventitia, or sometimes with perivascular hematoma.
Okay, perfect.
That's the difference in the content of the composition of the blood vessel wall.
Perfect. Okay, that's a very good description of the pseudoaneurysm versus aneurysm differences. So how do they usually present to the emergency department? What are the classical signs of presentation?
Typically, they have abdomen pain or back pain or hypotension, or they just feel unwell. Syncope, as we talked about, one of the big and bad things which can cause syncope is aortic pathologies, dissection, aneurysm, but otherwise abdomen pain, back pain, low blood pressure, looking unwell. Sometimes they can have pulse deficits. If the aneurysm itself gets thrombosed, there is almost always a layer of thrombus around the aneurysm.
Yeah.
If the whole aneurysm gets thrombosed, you can have pulse deficits or acute limb ischemia, that sort of problems.
Okay.
But the typical presentation is low blood pressure, abdomen pain, back pain, passing out. Sometimes you also see hematuria. This is one of the classic things that's always taught. Whenever you see hematuria in somebody more than 50 or 60 years old, make sure they don't have an aortic aneurysm, and you either need to get them a bedside ultrasound, or if they're really unwell, I think they should get a CT scan. My personal threshold, and I think most people would agree, the older you are, your risk of having something big and bad in your abdomen increases if your chief complaint is abdominal pain. So you should really have a low threshold of getting the CT abdomen pelvis done for geriatric population. So that was about the typical presentation of aortic aneurysm. And most cases don't present typically. They can have long-standing chronic back pain as well. So how that can happen is if they have, now the rupture of aneurysm is sort of two types. One is a contained rupture and one is the free rupture. When you have a free rupture of aneurysm, you sort of become with acute abdomen pain, distension, and hemorrhagic shock. Essentially, you die if you're not treated within a few minutes.
Okay.
When talking about contained rupture, if you bleed in your retroperitoneum, if you're ruptured in your retroperitoneum, you can contain the hematoma, and that can cause chronic back pain, sometimes weeks, sometimes for months. So chronic back pain, as in not years, but a few weeks or few months of back pain, you should still suspect aortic pathology. You should still have a low threshold of getting at least a bedside scan for these people.
Okay, perfect. So the bottom line is, if somebody is 60 plus and complains of abdominal pain, you should always think of abdominal aortic aneurysm or dissection in the emergency department and try to rule it out. I'm not saying that you should get scan on everyone, but always think of AAA and try to rule out either by history, examination, or maybe some imaging modalities. So is that correct?
That's correct. I would really have a low threshold to put the ultrasound probe on these people. Again, with history, we should really have a high suspicion, and we are finding out more of these because we are scanning more people. And it's difficult to estimate the true prevalence or the true incidence of this disease, because essentially people, if they can also cause sudden deaths if you have intraperitoneal or retroperitoneal rupture. So have a low threshold. Any concerns, abdomen, back pain, syncope, somebody looking unwell, old, vasculopath or arteriopath, smoker, hypertensive, big risk factors, previous aortic surgery, they should just get a CT scan if they've got previous aortic surgery.
Okay. So talking about the natural course of how the disease progresses, could you tell me a bit more about what happens if it is left untreated?
So in terms of complications, if you don't treat the disease, now there are a few complications that,
apart from death,
that's the worst complication. So one is rupture. I've briefly talked about free rupture, where it's unlikely that you would make to the hospital, or even if you'd make to the hospital, you need to be rushed to theater immediately within minutes. The other one is contained rupture, where you can have chronic weeks or sometimes months of back pain, which is the hematoma is contained. So rupture is one of the complications. The other one is it can cause thrombotic disease. If it gets thrombosed, you can have pulse deficits, lower limb ischemia, chronic limb ischemia. People who come with history of chronic limb ischemia, Berger's disease, chronic big time smokers, when we call it acute limb ischemia in the emergency department, they often get their whole vascular system checked, including the aorta, to see if the thrombus actually came from their aorta. So thrombotic disease is one of the complications. And the other one is embolic disease, which is again acute limb ischemia. If they throw an embolus into one of their lower extremities, femoral or popliteal or kind of lower down blood vessels. Other complication is because of compression. Long-standing aortic aneurysm, now I wasn't aware of this, can cause weight loss, vomiting, bowel obstruction if it kind of compresses on your second or third part of duodenum. So it can present like this in elderly population, chronic aneurysm causing bowel obstruction. It can also cause obstruction of your genitourinary tract. If you've got somebody with hematuria, a 65-year-old, big-time smoker, good risk factors for aortic disease, got hematuria, you scan that, you've got a hydrohydronephrosis, then you might still think, oh, is this renal colic? I would say just scan anybody more than 60 or anybody more than like even 50 if they have got risk factors. They should get CT scan to confirm the diagnosis of renal colic. Again, it's important to look for other pathologies as well. If you don't find a renal stone, the CT also gives you much more information. So it can cause bowel obstruction, genitourinary tract obstruction, which kind of muddles the picture with the renal colic. So I would be really, worried if you call some 65-year-old colic, and I would just say we should probably scan him today or tomorrow or ASAP just to make sure there's nothing else we are missing. The other two big complications, I'm going to take a few minutes to talk about these. Now, these are really important, rare, but really important now. The first one is, sure most of us have heard about, is aortoenteric fistula, which is a fistula between your aorta and your gastrointestinal tract because of peri-aortic inflammation, which can happen sometimes in infectious aneurysms or any other aneurysms. You kind of erode into your GI tract. And then you can form abscess there. You can leak blood from your bowel blood vessels, which can initially be a small GI bleed, can be hematemesis or melena. Eventually, when the aorta ruptures in your GI tract, you will have a profound torrential upper GI bleed, which might present as hematochezia, which is fresh red blood per rectum, and which can happen in upper GI bleeds. So anybody with history of aortic surgery, with a graft or any aortic repair coming with GI bleed, we should always think of aortoenteric fistula. Even without history of surgery, somebody has got aortic aneurysm, it can sometimes rarely leak into the bowel or erode into the bowel without any surgery as well. So spontaneous aortoenteric fistulas are possible, and we should just resuscitate them really quick and get them to theater as soon as possible. The other complication is aortocaval fistula, which is a fistula between aorta and one of the veins, typically inferior vena cava. So imagine if you develop a fistula between your abdominal aorta and inferior vena cava. And again, because of peri-aortic inflammation, kind of erode into your IVC. You would compromise blood flow to your lower extremities. Your lower extremities will turn edematous acutely. They will turn cyanotic. All the veins on your lower extremities and on your abdomen, superficial veins, are going to distend. And that's happening really acutely. And what's happening up there is, so you've got high pressure blood flow from aorta coming into IVC, which is going down to your lower extremities, venous distension of your lower extremities, and also venous distension of your upper extremities, raised AVP, acute heart failure, high output heart failure, acute pulmonary edema. And you can also, very interestingly, rupture veins of your bladder, causing hematuria. And also you can rupture veins from your rectum, causing a GI bleed or sort of PR bleed, which you may think, oh, it's GI bleed. So anybody with history of aortic aneurysm coming with hematuria or GI bleed can be from superficial veins. And if they look really unwell, they are possibly in high output heart failure because of a spontaneous aortocaval fistula. When I was reading about this, the first article I found on Google search was done by one of the case reports by Dr. Salmon Lee Smith, who was one of our consultants at Edinburgh Royal Infirmary. So it's very interesting, and they also call it, I think, bursting heart syndrome or something like that. So aortocaval fistula, that was very interesting, and one of the rare complications. Quickly, in terms of complications, aortocaval fistula, aortoenteric fistula, aortoiliac, kind of thrombotic disease, embolic disease, lower limb ischemia, and then rupture is the most deadly and the most talked about, most well-known complication. I think we don't talk enough about aortocaval and aortoenteric fistula, and we should be more aware of them as acute emergency healthcare providers.
Perfect. Thank you for talking about these two not so common but important entities. Moving on forwards, what do you think is the role of point of care ultrasound? And if you find, say, a AAA on ultrasound, will you be able to say if it is dissected or not? And also, if you don't find free fluid on your scan, does that rule out a leaking abdominal aortic aneurysm? I know that's kind of a loaded question.
Right.
Too many.
So the first part of your question, dissected aneurysm. Now, I wouldn't be able to say, probably say if it's a good going flap. I can say this is probably a flap, but again, dissection and aneurysm, these are two different entities. However, having said that, aneurysm and aneurysmal aorta can dissect. but classically these are two different entities. I cannot comment, or the evidence, I shouldn't say I cannot. What I'm saying when I say I mean the evidence suggests that we cannot comment reliably about leaking aneurysm based on the ultrasound findings. If I've got free fluid intraperitoneal and somebody I can see an aneurysm, it's like, and somebody looks unwell, it's likely it has ruptured. Most of the times the rupture is retroperitoneal, and retroperitoneal fluid is not picked up by fast or a bedside ultrasound scan. So normal negative free fluid on fast exam and an aortic aneurysm, abdominal aortic aneurysm, somebody looking unwell, you cannot rule out a leak. You cannot rule out dissection, of course. You cannot rule out leak. It's just to diagnose the aneurysm. And if somebody is unwell, I would presume he's unwell because of the aneurysm, and try and get advanced imaging for them ASAP.
Perfect. Okay. So imagine you have diagnosed AAA in the ED. What would you do next? What are the next steps that you need to do?
If somebody's unwell, now if I've diagnosed with CT or ultrasound, let's say I've diagnosed with whatever, it doesn't matter. So let's, I've got the diagnosis. First thing I'm going to do is make sure the patient has 2 IV access, wide bore, at least 18 gauge or maybe 16 or maybe even 14, the orange or gray one. And the most important test here is, of course, we'll do a blood gas to see the hemoglobin and the arterial base status, the bicarb and lactate, that sort of stuff, and hemoglobin as well. But the most important test is cross-match, arranging at least 6 units. If needed, sometimes we need to activate the massive transfusion protocols or the major hemorrhage protocol based on your local,
guidelines,
activation system and guidelines. Cross-match is the most important test. We should essentially treat them or give blood to them like major trauma, or what you call as code red or level 1, kind of the sickest trauma patients. We should give them blood like that, because if you give them too much fluids, that will dilute their coagulation factors, that will lead to dilutional coagulopathy and worsen the acidosis. I presume they will already have an existing acidosis because of some acute kidney injury that they may have had because of compromised renal blood flow. And it will just worsen their coagulation parameters, and bleeding will worsen the bleeding as well. So to our wide bore IV access cross-match, I'm going to call vascular surgeons ASAP. I'm going to try and organize imaging for them if they are relatively well. But the most important thing here is to call vascular surgery and even call anesthetics and call theaters to make space for them. Of course, this should happen within a span of minutes. These patients shouldn't be in the emergency department for more than 30 minutes. And I would just go ahead and say it's a waste of time to resuscitate them, because you need to control the blood pressure. Or you need to control the source of bleeding. And that will essentially happen in the theater. Coming to controlling blood pressure is a bit controversial. If somebody with aortic rupture, aortic aneurysm comes with a blood pressure of 170 or 120, it's a bit controversial whether you should treat them or we shouldn't. The guidelines differ. Speak to your vascular surgeons what they want, whether they want you to give IV antihypertensives or they just want you to hold off and give blood. But definitely in terms of management, 2 wide bore IVs, arterial line, if you can get that done to get the exact blood pressure. Give them blood if they are really compromised. They are obviously shocked, and controversial to give them antihypertensives. The other thing for them would be, it's best to avoid intubating these patients in the emergency department, because they will crash. They are already, they've already lost a lot of blood. I presume they are really sick. Typically, the guidance is, again, controversial. We should maintain a blood pressure of about 80, 90 systolic blood pressure. Just make sure they've got decent pulses, a really decent radial pulses, a reasonable urine output if you've managed to got the catheter in. So
and they're celebrating well, and their consciousness.
And yes, of course, mental status. If they are talking to you, if they've got a blood pressure of 75 on arterial non-invasive blood pressure, I would probably leave them there. I wouldn't give them too much blood, too much fluids, but I would keep blood ready, and they will probably need blood as soon as they go to theater.
Perfect.
It's also worth mentioning, sometimes the repair can be done in local anesthesia or with sedation, the endovascular repair, and they don't really need general anesthesia. So it's best to avoid intubation. And if they need intubation, we should give them high doses of paralytics and low doses of sedatives. Even ketamine is known to cause drop in blood pressure. So low dose sedatives and high dose of paralytics. So that's essentially about the management.
Okay, perfect. I think
you should just go to theater as soon as possible. That's the bottom line. You should make that call, and they shouldn't be in the emergency department for more than definitely 30 minutes is even way too much. So as soon as possible, they should just.
So the definitive management is mostly surgical.
Absolutely.
Perfect. So coming to the last part of the question. So if you diagnose abdominal aortic aneurysm and the patient is asymptomatic, it has an incidental diagnosis, what would be the next steps? How would you follow them up?
It depends on your local system, essentially. You can either call vascular and arrange kind of surveillance for them for regular scans, and or you can send them to their primary care provider, but make sure that they know this is a serious problem. I would in fact sit with them and have a chat with them about their lifestyle modification. If they are smoking, they should definitely just stop smoking. It decreases your growth of your aneurysm by 20%. So that's the best thing you can do to your health in every way. Just stop smoking, and then get to your GP. Make sure you get followed up. Make sure the vascular surgeons in your area know that you need to see them. You need to come back for another scan, because the guidance, again, it's 5 to 5.5 centimeters. If you've got more, the diameter of more than 5 to 5.5, you should probably get elective repair done. Or if it increases more than 1 centimeter a year, then again, you should get elective repair done. But no aneurysm is safe. 3.5, 4 centimeters can also rupture, but it's just about the risk is much less. So they should know they have to follow up, and they shouldn't lose the follow-up. So either through the GP, the general practitioners, or to the vascular surgeons if they are asymptomatic. And if you are really sure that this is not the cause of their symptoms.
Okay, perfect. And they should also know about the red flag symptoms and when to come back in case if they develop any new symptoms.
Absolutely,
Perfect. So I think we've covered most of the things, and I think we'll stop here. If you have any questions, please ask in the comments box and we'll be happy to answer. Thank you very much.
Thank you.